Well, first of all, welcome everyone. Thank you so much for coming to this wonderful session on in-depth discussion about sarcoidosis, which is, as people know, a very serious condition, and I think we're really looking forward to this. Especially also, we're looking forward to the fact that this is co-sponsored by Lantern, the Asian Lupus Network, and so we're really delighted to have Eliza here too to kind of introduce or to discuss a little bit more about Lantern. I'm going to hand the mic over to Eliza.
Thank you, Dr. Lee, and thank you, Jamie. Good evening. I'm so delighted to be here tonight, and thank you very much for this collaboration opportunity. Can you all hear me okay? Yeah. So, yeah. My name is Eliza Nan. I'd like to tell you a little bit about our program, Lantern Lupus Asian Network at HSS, Hospital for Special Surgery. Lantern is a support and education program, especially for Asian lupus patients and their families. As you can see from the screen I'm sharing right now, we provide a range of culturally adapted services to help patients to cope and manage the conditions. Furthermore, we rely on our partners in professional healthcare, such as you at CAMS, Chinese American Medical Society, to help increase lupus awareness in the Asian community. Early diagnosis lead to timely treatment and better outcomes for diseases, especially for lupus. As you may know, Asian culture is unique, but may impact adversely how patients manage their health. For example, Asians are generally shy or reticent to speak up about their emotions. The psychological impact, in addition to physical symptoms of living with lupus, can be overlooked sometimes. Prolonged suppression of negative feelings may lead to increased disease activities or other related issues. Lantern is here to help. We appreciate our partnership with you to help us spread the word and welcome any referrals of patients who may benefit from our services. As you can see on the poster, we have a toll-free support line for peer counseling and a bilingual website full of resources and information. So please feel free to reach out should you have any questions. One last note, at the end of the meeting, we have an evaluation survey that we will appreciate you to fill out before you go today. I will post the link in the chat box towards the end. We value your feedback, so please kindly take a minute to complete. Thank you very much. And I'll turn over back to Dr. Lee. Thank you.
Well, thank you so much, Eliza. This is great information. I forgot to introduce, I'm actually a nephrologist at Weill Cornell. I'm the co-chair with Wenhui Li as the research committee. So we are really delighted to actually have two great speakers today, Dr. Ken Sha and Dr. Arthur Yi. And I would love to give you a little bit more information if you don't know them already. Dr. Ken Sha is a clinical assistant professor of medicine at Weill Cornell, and she's specializing in pulmonary and critical care medicine. He obtained his MD degree from the Institute of Medicine in Rangoon, Burma. He completed his internal medicine and residency at the New York Hospital Center of Queens and a fellowship at State University of New York Health Science Center at Brooklyn. A true kind of expert in pulmonary diseases, and we're really looking forward to hearing his talk. He's going to give the first talk, and then we also welcome Dr. Arthur Yi. He's an assistant attending at HSS and assistant professor of medicine at Weill Cornell Medicine, specializing in rheumatology. And his expertise is sarcoidosis, which is the topic here, so we're really looking forward to that. But he's also an expert in spondylopathies, rheumatoid arthritis, gout, and crystalline arthropathies. Dr. Yi completed his undergraduate studies at Princeton and obtained his MD and PhD degrees at NYU. He completed a residency program in internal medicine at Weill Cornell and a fellowship program in rheumatoid in rheumatology at HSS. He has published numerous articles on rheumatological diseases, particularly sarcoidosis. So we're looking forward to having both speak today. Dr. Sha, would you like to start?
Sure, of course, sure. Everyone hear me okay?
Yep.
Good evening and hi to everyone joining us on this Thursday evening for the CAMS Journal Club. And like Dr. Lee introduced, my name is Kenneth Sha, a pulmonologist in Flushing, New York. And I would like to thank, first of all, to Dr. Victor Chang, CAMS, and London for inviting me to participate in today's interesting journal club. And my presentation is going to be about a poster presentation that my pulmonary fellow and I did in 2007 for the CHEST Annual Scientific Conference, and it was published in CHEST Journal in October of 2007. And the presentation was titled as Sarcoidosis amongst Chinese Americans. As we all know, sarcoidosis is not a common disease in Chinese Americans. And when we think about sarcoidosis, we think about other ethnic group and patients of other ethnicities having the diagnosis and not the Chinese Americans. However, we started seeing them or we started recognizing them. So sarcoidosis has been observed in many different parts of the world, and incidence is highest, according to the literature, among the Swedish, Scandinavians, African Americans, and it's quite low in the American Indians, Eskimos in Canada, and the Chinese. So before our presentation to CHEST, there weren't that many documented sarcoidosis case reports in the literatures. And there were about 15 cases reported from Hong Kong in 1981. And it's been believed that sarcoidosis is more common in the cooler northern latitudes. That's been a couple of reports stating that, and it has not been reported again in the immigrant Chinese living in North America and Europe. So when we found, or when we diagnosed one of our patients, a female Chinese immigrants in Flushing with sarcoidosis, we felt that it would be quite interesting to do a retrospective chart review to find out how many Chinese patients in our institution actually were diagnosed with sarcoidosis. So what we did was that we went back about 11 years of data in our hospital. A hospital, for those of you who don't know, it's NewYork-Presbyterian Queens, or New York used to be called Booth Memorial Hospital. Now it's NewYork-Presbyterian Hospital of Queens. It's a community hospital. It served broad multi-ethnic populations, and according to U.S. Census Bureau, 56% of the population in Flushing area are identified as Asian, and predominantly of Chinese ethnicity. So it's a good institution to do the retrospective study to find out how many of us actually have sarcoidosis. So we did the medical record database review using the CPT code for sarcoidosis, for mediastinal granulomas, for the mediastinoscopies procedures, and then we also matched with the ethnicity or the race that was entered in the medical records. So we identified, after the review, we have 7 patients who were diagnosed with sarcoidosis, including our patient, our index patient that we found. In our case report, we briefly mentioned previous case reports or the publications of the sarcoidosis in Asian populations. The most recent one prior to our publication was in 1981 with 15 patients published by Dr. Ong and the group. That was from Hong Kong, and the documented Chinese population in Hong Kong have diagnosis of sarcoidosis made when they were presenting with, or they were evaluated for mediastinal adenopathy. So to make the brief descriptions of our findings, we found that our patients, including the one that we consider as our index patients, Chinese patients immigrated from Taiwan, many of them, and more female than male, and mostly have intrathoracic involvement, meaning they have adenopathies, and they have lesser incidence of hypercalcemia, hyperglobulinemia, etc. And also they have less extrathoracic manifestations such as eye involvement, renal involvement, and so on and so forth. Although it has been seen, and actually our index patient after our write-up started having presentation or the symptoms of hypercalcemia, and she was admitted to the hospital a few times for hypercalcemia treatment, actually. So again, never say never. During our presentations of that case write-up, we thought that there were less, but maybe we might be a little off there. So conclusion is basically that we have made diagnosis of sarcoidosis in Asian Americans. It is not unheard of anymore, and we should be having this diagnosis as part of our differential diagnosis when we see Asian American patients with mediastinal adenopathy. There is it's a brief description of what we have published then, and I think I'm gonna give the microphone back to Dr. John Lee and Dr. Arthur Yi.
Yeah, thanks, Dr. Sha. That it's really important subject, and actually even I didn't know that it's quite rare. And it's good for you to be able to describe this. But no, thanks so much for describing your publication in Chest. I think our next presentation by Dr. Yi. Dr. Yi, are you able to?
Yeah. Thank you. I have a question for Dr. Sha. Thank you for that.
Sure.
So your abstract came out in 2007, covering years, about 11 years before that. Have your observations changed since then? Do you still think that it's still a relatively uncommon, rare condition amongst Chinese Americans?
It is a less common diagnosis than other diagnoses that we see when we see adenopathy, obviously. We have seen more of, neoplasms and, infectious-related granulomatous processes such as TB, MEI-related adenopathies. Yes, sarcoidosis is not unheard of, it's not rare. I wouldn't say it's rare, but it's less common than other diagnoses. But we have seen a lot more actually since our publication. But yeah.
Well, first, I want to thank the organizers, John and Victor and Eliza, for inviting me to this talk and for you to spend, well, it's a hot Thursday evening, so it's probably better to be indoors anyway. But it's a relatively small group, so I hope this could be a dialogue as opposed to a didactic session. In full disclosure, even though the Lantern people who arranged this is not about lupus. And also in full disclosure, not that this is a bait and switch, this is really not, my talk is not about Chinese Americans and sarcoidosis. The topic of my talk is actually the evolving landscape of sarcoid. But I really thank Dr. Sha for introducing this talk, because it's a nice takeoff point to what I'm going to be presenting. So I'll share my screen right now. All right. So does everyone see my screen? Yes? Okay. So My disclosures, really nothing, no commercial financial relationships. I do speak for the Foundation for Sarcoidosis Research, and I am a contributing editor to the medical letter, but these are non-for-profit organizations. So I didn't know much about sarcoid, but I was told about it before I even started medical school by a friend who was a pediatrician, and he said to me when I graduated from college that when you're on rounds and you don't know the answer, just say, could be sarcoidosis. You'll look smart, and no one can be sure that you're wrong. And this really intrigued me because of the way I like to think, and it's really a nice contrast to what Dr. Sha presented, because traditionally speaking, as we'll see, sarcoid had been seen as a pulmonary disease. But what appealed to me was the fact that it was a disease that could affect potentially any part of the body, and hence often called the great mimicker. Shown here, and this is something I stole from the Chest Foundation, are some of the more common organ systems that can be involved in sarcoid. The lung has already been spoken about, as have been the lymph nodes, but the liver and the skin and the eyes are very common areas to find sarcoid. The two most alarming, actually quite concerning areas of involvement are the CNS, and more recently the heart. And one of the reasons why I raised the question before is because with new diagnostic modalities, we're seeing a lot of consultations for cardiac sarcoid, particularly cardiac PET CT and cardiac MRI. So it may be that it's very, very common in the lungs, but it's possibly common in other organ systems that we hadn't really thought of before. I've seen sarcoid in as bizarre organs as the prostate and the gums. So there are certain organs I've not seen in it, and I'm sort of looking out for them. But I wouldn't be surprised if you can find it anywhere. And so the thing that really comes out of it is that patients will enter the medical system based on whatever organ presenting system is there at the beginning. And so this is a pretty famous fable where you have 6 blind scientists or doctors looking at the same thing, but because they feel different parts of the elephant, they think that an elephant looks something completely different. And in many ways, this is where sarcoid has been, and part of my mission has been to bring us to the next level. So sarcoid is not exactly a rare disease. It's an uncommon disease. These are some of the conditions that we as rheumatologists are responsible to knowing about. It ranks there along with lupus. And so we've all seen lupus patients, and I'm sure we've all seen sarcoid patients, even if we didn't know it. The FDA definition of a rare disease is 60 per 100,000. So it's kind of in that range at the border between rare and uncommon. So it's not something that we should ignore. We should definitely be aware of this condition. As a rheumatologist and something of an immunologist, I think of sarcoid more mechanistically. This is the classic, the hallmark of what sarcoid is, and this is a non-caseating granuloma seen on a lymph node biopsy. We see here somewhat normal architecture with normal-looking lymphocytes. These, of course, are the non-casing granulomas with the macrophages surrounded by rims of lymphocytes. Don't ask me anything more on that. It's for me, it's kind of like pornography. I know it when I see it. But this is really what's pathognomonic about sarcoidosis and what's really infiltrating the tissues in individuals. Dr. Sha may be familiar with some of the names I'm about to mention. This is Morten Kveim, who was a Norwegian pathologist, dermatologist, I believe, who devised Kveim test. This was a test where they took extracts of lymph nodes from sarcoid patients, injected it intradermally, and allowing for reaction to occur over several weeks. And if there is a reaction, they will biopsy it, and you'll see granulomatosis inflammation in the skin biopsy, and that was what they used to diagnose sarcoid. Louis Siltzbach was, I believe, a pulmonologist at Mount Sinai. He kind of refined this test and introduced the use of corticosteroids when they became available in the 50s as the first really effective treatment for sarcoidosis. This is John Scatting, who really put sarcoid as a disease on the map. This is a book that I actually found on eBay, which was printed in the 60s. It was his life's work in this area. As a side note, John Scatting was Winston Churchill's pulmonologist and treated him during World War II for pneumonia. But later on, developed what we now know as the Scatting stages. So if you don't remember or never learned it in medical school, the Scatting stages are a way of grading radiographs, lung radiographs, 1, 2, 3, and 4, based on findings of lymphadenopathy, interstitial lung disease, and fibrosis. And there are some prognostic implications to that, but we're not going to delve too deep into that. However, what I want to bring up was, historically speaking, say up until pretty much the time period that Dr. Sha was describing, I would call this the Siltzbach-Scatting legacy. That is, sarcoidosis is a pulmonary disease, and that corticosteroids are the foundation of therapy. And I think right now we're at a place where there is a gradual shift away from these two underpinnings. Not to say that sarcoidosis is not a pulmonary disease. It obviously most often does occur in the lung, and not to say that corticosteroids aren't useful, but we have to sort of go beyond these two axioms. The reason, of course, with steroids, there are a lot of adverse effects, and over the course of many years, many medications that we're familiar with have been used with the goal of controlling disease without the use of steroids and its risk the concomitant adverse effect of steroids. Repository corticotropin is kind of a steroid, so I don't really count that, but medicines that like methotrexate, azathioprine, mycophenolate, leflunomide, a lot of the medicines that the transplant people know about, the oncologists would know about, and of course, rheumatologists know about as well. Other medications that are rarely used include hydroxychloroquine. Thalidomide is a very interesting medication that obviously has some bad press, but can be very useful in select patients as well. Cyclosporin, and in very severe cases, cyclophosphamide. Now, these medicines that I have here were tried kind of on a, okay, well, it's an immunological disease, and these are exactly how they work in the immune system, but we know they do, and so we'll try them. And sure enough, they can be very useful in sarcoid. However, they are very general, very broad, and it would be nice to be able to be a little bit more finer in terms of treatment. So I'm going to take a little bit of a digression at this point. This is a picture of me, roughly 1985, with my thesis advisor, Y.K. Yip, who was a associate professor at NYU. He actually a very modest man with very extensive accomplishments, but never recognized for it. So I sort of put a shout out to him now. He was the person who actually purified and characterized type 2 interferon in 1981. And he also, and part of my thesis work, was in the characterization of type 1 interferons in lupus, which those in the lupus world now know has led to the development of a monoclonal antibody against type 1 interferon for lupus. So it's nice to see that come to full circle. YK actually trained under this gentleman, who's a lot more famous, Jan Vilcek. Jan Vilcek was a Czech immigrant, became professor at NYU. He was truly one of the pioneers in cytokine research, notably in interferons, and at the time an intriguing molecule known as TNF alpha, which was known to be a powerful pro-inflammatory cytokine secreted by macrophages. In his work, he and his colleagues developed as a research tool a monoclonal antibody against TNF alpha, which we now know as infliximab. And this was in the late 1980s. And I like to say that I actually met the mouse in which infliximab was originally made. And by that time, I was finishing my PhD, going on to my clinical work, and sort of thought I'd left that side behind me, but we'll see in a moment how life has a way of turning things around a bit. About the time of the work that I was doing, this paper came out, which I've found interesting going back to. And this was a work which showed that TNF, tumor necrosis factor, was important in the development of granulomas. And so this was a mouse model in which mice were exposed to BCG and asked, what were the immunologic mechanisms for granuloma formation. I mean, Cell papers were like 10 pages long, so we're not going to go through all that. But I picked out two interesting observations that will make some of the points that I want to raise. First of all, if you gave anti-TNF antibodies to these mice, you would blunt the granuloma formation. So here in panel A, you see the granulomas form. And in panel B, you have this sort of blunted response here, okay? So this raised the point that TNF was important in granuloma formation. Other data like TNF deficient mice, knockout mice, for example, they don't make granulomas either. So that would be the other approach that you could take. The second point I want to make is this, and try to follow with me. This is a little bit convoluted without all the background. So if you stimulated these mice with BCG and you added more TNF to the mix, what would happen is that the macrophages would make even more TNF. Okay, so this is a northern blot where you added TNF, and what you see is increased TNF mRNA expression when you stimulate it with TNF. So there's this autocrine loop that is created. The other thing that they saw was that this effect was enhanced by interferon gamma, or type 2 interferon. So here, for example, in lanes 1 and 2, which is the same as panel A. So if you gave TNF, you made a little bit of TNF mRNA, but then if you added gamma interferon to that mix, you really hyper-enhanced that expression. So based on these data, you came up with this model. So this is from the Hopkins group, and this shows a general framework in terms of how we think that granulomas form. You have some sort of trigger. It could be some organism, or perhaps some inorganic or organic substance, causing T cell activation through interaction with a macrophage. This interaction results in the production of TNF alpha, which then causes the formation of the granuloma. And this can be enhanced here by interferon gamma. And importantly, the TNF is made by the granuloma itself, so it feeds itself. Okay, so once it forms, it just sort of makes more food for itself and perpetuates. So this could account for the chronicity of the disease. Okay, so the bottom line, TNF, interferon gamma, both important in the production and perpetuation of granuloma. All right, so out of grad school, back into the clinic, became an attending. This is alongside Klein and Silsbach and Scatting. This is, in my view, probably the fourth most important person in sarcoid. I'm a little facetious. This is Betty Ring, and I'm allowed to use her name because I've been permitted to use it. Betty Ring was a woman that was introduced to me in the late 90s by a colleague of mine who was a gastroenterologist for an unusual presentation. So Betty was a 72-year-old woman who presented in 1999 with a protein-losing enteropathy, presenting with refractory diarrhea. She lost so much protein that her serum albumin fell to 1.8 grams per deciliter. And the other notable abnormality she had was she had a normocytic anemia. She also had some proximal muscle weakness with muscle enzyme elevations, but not to the degree that we would see in myositis. So somewhere, say, in the several hundred range as opposed to several thousand range. But she became so weak that she was wheelchair bound and really could not raise her arms over her head on her own. An extensive workup was done, really a fishing trip, ultimately revealing some lymphadenopathy in the axilla, and the precarinal area and the pretracheal area, and multiple small non-specific pulmonary nodules. Too small to biopsy, but they were able to biopsy the lymph nodes, and because of anemia, they biopsied the bone marrow as well, and both showed non-caseating granulomas consistent with sarcoidosis. So at least we had a diagnosis, but unfortunately, because of her gastroenteropathy, we had no medicines to give her, because anything we gave her would just flush out, right? So we were really stuck. In 1998 or 1999, that monoclonal antibody that Jan Wilczek made became a hit. It became Remicade and became approved for rheumatoid arthritis and inflammatory bowel disease. And given my recollections of the pathophysiology of granulomas, I said to my colleague, let's try it. So this is Betty's serum albumin through the course of treatment. So let me walk you through this a bit. So our baseline is roughly in this range. This correlates about 2 milligrams in our lab, but it's 2 grams per liter. These little asterisks represented IV pulses of steroids, and we thought that maybe we had a little response, but it really wasn't sustained. And then these open arrows represent times where we gave Remicade infusions. And in those days, you gave 3 doses and you call it a day, all right? So we gave 1 infusion and there seemed to be a little bump up. We gave another infusion, and lo and behold, by the 2nd or 3rd infusion, she had normalized her serum albumin. Not only that, her diarrhea stopped, and not only that, she literally walked out of her chair. So this was like, if you remember the movie, what, Awakenings, when the Parkinson's patients jumped out of their chairs when they give DOPA, the exact same thing happened with her. So this we published in the annals and led to other cases where we tried it. This is an example of cutaneous sarcoid. You see here in her this patient's nose, classic lupus nodules, and with infliximab, they all melted away. This was a very striking case. This was the gentleman I spoke about with the gum sarcoid. So when I met this man, he had had a lot of dental procedures and ultimately was diagnosed with granulomas in the gums. He also complained of periorbital paresthesia, which he had attributed to all the dental work. We worked it up further, and what he had was inflammation of Meckel's cave here, which is where the trigeminal nerve comes out. And so that's what accounted for his paresthesias. And then when we gave adalimumab, which is another monoclonal antibody to TNF, you see that the enhancement disappeared, the numbness improved. This is, again, this is the scariest manifestation of sarcoidosis, cardiac sarcoid. So this is a PET CT of the heart. The top is baseline, and this enhancement under PET scan showed FDG uptake in the myocardium. This patient, I don't remember what his presentation, but the typical presentation is either heart failure or arrhythmias. And when we gave adalimumab, you see that the enhancement improved dramatically. So those were kind of more anecdotal things, case by case. I mean, the momentum began to build for justifying infliximab for treatment of sarcoid. Then came, of course, RCTs, randomized controlled trials. So this is infliximab for pulmonary sarcoid, baseline, placebo here. These are PFTs, I'm sorry. And so these show improvement from baseline in patients treated with infliximab. Similarly, for cutaneous lesions using a third antibody called golimumab, you see there's improvement in the treated group here at the bottom in terms of skin scores. Eye disease, so this is a little bit of a bait and switch, because this was in all patients with uveitis. About 10% of these patients did have sarcoid. The lower bar, lower curve shows the treated group with fewer relapses after discontinuation of therapy versus placebo. And this is the only study, and this is the biggest challenge we face in sarcoid now, is that because it's a multi-system disease, it's really hard to treat the more complicated cases, but this was one attempt. So this represents disease activity scores, and so the lower the better, and the lower curve represents the treated group, and the upper curve shows the placebo group. And so clearly you see benefit in this group as well. These are just all the different trials that I cited. One important note, not all TNF inhibitors are the same. Etanercept, otherwise known as Enbrel, is not a monoclonal antibody, but rather a soluble receptor. This does not work. And one reason we think is that because it's a soluble receptor, it doesn't have a chance to stick to the granulomas. It just sort of circulates. So it doesn't have this exact same mechanism of action. So, so in terms of medications, only the monoclonal antibodies against TNF work. All right, so now how about interferon gamma? And I have a couple of minutes and that'll be it. So this is sort of the newest thing that's currently in evolution right now. So interferon gamma is a cytokine which binds to its receptor and mediates through a family of kinases called JAK kinases. And now we have several medicines that are that inhibit JAK kinases. So this is from the New England Journal, from the Yale group. Patient with cutaneous sarcoidosis. Here you see these lesions, and this patient was treated with a medicine called tofacitinib, which is approved for various indications at this point. And here are the scores. When the medicine was administered, the skin scores improved. With discontinuation, the skin lesions came back. improved, came back, and then finally they decided, well, we'll just give the patient the medicine and leave it a day, and continued to improve. And you can see how the lesions improved externally. Biopsy, you can see why that is. So here the granulomas pre-treatment, here is the absence of granulomas after treatment. In my hands, I've used it in other instances. So this is a gentleman with hepatic sarcoidosis. This is his baseline alkaline phosphatase, given the same medicine, and you can see his alkaline came down quite nicely, close to normal. So these are various case reports in series using JAK inhibitors. I published one in a patient with skin and joint disease who had failed everything else that we had to offer, including TNF inhibitors. So JAK inhibitors are a really nice addition to our armamentarium. So we're at a crossroads now in terms of sarcoid. What Kenneth described is kind of like up here. There's an eminent pulmonologist from Hopkins who I spoke to at a meeting, and he basically said, sarcoidosis is a steroid responsive disease, and if the patient's not responding, you're not giving enough steroids. That could be true. You'll also kill the patient with the steroids. And then a different pulmonologist at the same meeting got up and said, well, I've been asked to talk about new therapies for sarcoid. So the first thing I did was walked over to rheumatology and see what they're doing. So right now, again, we need the expertise of all these scientists looking at the elephant, people who really know the organ systems, but also people who know the medication.